Hello, I'm Robert Bechara, a gastroenterologist and advanced therapeutic endoscopist here at Queen's University Kingston Health Sciences Centre, Kingston, Ontario, Canada. It's really a pleasure for me to discuss our IGIE paper on behalf of my co-authors. Our article focuses on pharyngeal ESD for superficial pharyngeal squamous cell carcinoma. When these cancers are detected early and selected appropriately, pharyngeal ESD can offer a minimally invasive, organ-preserving treatment with excellent long-term and disease-specific outcomes. It also represents a natural extension of advanced endoscopic oncology. However, it remains far more established in Japan and in Asia than in Western practice. In this review, we summarize detection, optical diagnosis, indications, technique, outcomes, adverse events, and practical steps for broader Western adoption. During my recent sabbatical in pharyngeal ESD at the Ariake Cancer Institute Hospital in Tokyo, I saw the gap between what is possible and what is routinely available. In Japan, systematic pharyngeal examination and image-enhanced endoscopy have shifted detection towards superficial lesions suitable for endoscopic therapy. In Western practice, many early lesions are still not sought or even recognized, and pharyngeal ESD remains underutilized, although Western experience is emerging. The review is needed because the field has moved beyond proof of concept. The technique of pharyngeal ESD is mature in expert Japanese centers, but Western programs need a practical framework for training, collaboration, equipment, patient selection, and follow-up. In Canada, we have begun implementing this approach, so the key question is how to do it safely and reproducibly. Pharyngeal ESD is technically distinct because of the anatomy and working environment. The endoscopist operates in a narrow, fixed space, often very close to the airway, especially in the hypopharynx and the piriform sinuses. General anesthesia is mandatory, and most hypopharyngeal lesions require laryngeal elevation with a surgical curved laryngoscope to create visualization and adequate working space. Traction is also particularly important because it can improve exposure, stabilize the working field, and help reduce repeated contact with the larynx, which can precipitate laryngeal edema. Detection is a central part of this paper because the success of pharyngeal ESD starts before the resection. Most early pharyngeal cancers are very flat, subtle lesions and very easy to miss unless the pharynx is examined deliberately. A major message of this paper is that a brief, structured inspection of the oropharynx, hypopharynx, and larynx during routine upper endoscopy can improve early detection. Patient phonation can also help expose the piriform sinuses when visualization is limited. Once these lesions are recognized at an early stage, minimally invasive endoscopic treatment becomes a realistic option. However, without early detection, there is no possibility of early endoscopic treatment with pharyngeal ESD. Thus, detection is central to the establishment of a pharyngeal ESD program. Similar to the rest of the GI tract, optical diagnosis is critical for deciding whether a lesion is suspicious, estimating invasion depth, and determining whether or not endoscopic treatment is an option. Magnifying narrowband imaging or blue light imaging can reveal the microvascular changes associated with squamous neoplasia, and the Japanese Esophageal Society IPCL classification helps stratify lesions into patterns associated with increasing risk of deep subepithelial invasion and nodal metastasis. Lugol's chromoendoscopy also remains useful, especially for lesion delineation and confirmation of margins. But in the pharynx, it must be used with endotracheal intubation due to the risk of aspiration and severe pneumonitis. Patient selection starts with optical diagnosis and confirmation of superficial disease, without muscular invasion, nodal or distant metastasis, and lesion extent that is technically and functionally reasonable. Very extensive postcricoid or bilateral piriform sinus disease raises the risk of deformation, stenosis, and aspiration. In post-resection pathology, tumor thickness is a key component similar to the traditional SM1, SM2 categorization. However, because the pharynx has no muscular mucosa, the traditional invasion depth cannot be estimated the same way. However, tumor thickness of 1,000 micrometers or 1 millimeter and greater is a clinically meaningful predictor of lymph node metastasis. Post-resection pathologic features such as lymphovascular invasion, tumor budding, infiltrative growth, and deep margin status can also guide follow-up intensity and the requirement for further treatment. The outcomes are very encouraging, and across the contemporary series summarized in the review, on-block resection was about 98.4%, with an R0 resection of 78.5%, local recurrence about 4.6%, lymph node metastasis at 4.8%, and a disease-specific survival at 3 to 5 years of about 99.3%. Taken together, these data suggest that in appropriately selected patients, pharyngeal ESD can be highly effective in terms of oncologic treatment with excellent long-term disease-specific outcomes. Despite being a very safe and overall very effective procedure, the adverse events are not trivial. The adverse event we worry about most clinically is severe laryngeal edema. Most cases are mild and managed conservatively. However, clinically significant edema can require airway intervention. In the contemporary series, any grade of laryngeal edema occurred in approximately 8.8%, while edema requiring airway intervention occurred in about 1 to 2%. There are also important functional considerations after endoscopic resection, including aspiration risk and pharyngeal deformation, particularly after more extensive resections. For that reason, pharyngeal ESD should be performed in an experienced setting with strong endoscopy, anesthesia, and otolaryngology support. Western adoption has been limited less by the resection concept itself and more by the system around it. Early lesions are often not detected, and many endoscopists have limited experience with squamous optical diagnosis. Specialized exposure equipment may also not be widely available, and successful implementation requires close collaboration with otolaryngology and anesthesia. In many Western centers, the pharynx has traditionally sat outside the routine gastroenterology practice, which creates credentialing and structural barriers. Our early Canadian experience has reinforced this point that successful adoption depends on much more than technical skill alone. It requires building clinical, institutional, and multidisciplinary framework around the procedure. Going forward, I see 3 main priorities. First, we need better education in structured pharyngeal examination and early lesion detection. Second, we need focused training in pharyngeal ESD itself, particularly airway anatomy, exposure, traction, and resection techniques. Third, we need prospective Western registries so outcomes can be tracked, audited, and benchmarked against high-volume Japanese centers. If these elements come together, pharyngeal ESD will become an important part of minimally invasive endoscopic oncology in Western practice. The take-home message is that pharyngeal ESD is an elegant, organ-preserving treatment with excellent clinical outcomes in experienced hands. But its success begins with detection, optical diagnosis, careful patient selection, multidisciplinary planning, and the infrastructure needed to perform it safely. As early North American programs develop, we hope this review helps advance both the discussion and the clinical adoption of pharyngeal ESD.